Kaya sa pag-play yan.
I-visit lang. Sige.
Papatay na lang ng ano.
Hindi lang ganun.
Ano na kayo sa
Breast.
mabot na kayo? Breast na.
Tapos
So,
na. Kakatapos
tapos na sa lahat ng ano, ovary. So, ovary, okay na. Okay, so this is slide 14. Carcinoma inside cervix. So when we do the cervical biopsies, usually we look into the presence or absence of ATP in the cells. So majority of cases that we have would be more of inflammation. Okay, usually we get chronic cervicitis in cervical biopsies. And then we look for any signs of atypia into the cervical epithelium. Prepare pa lang muna natin. Normal epithelium like this one. Okay, so you can see the basket weaving. You have the basket weaving over here. You have the basal layer. Okay. On this portion, you have good maturation of the stratified squamous epithelium. So when you say you have good maturation, there will be a diminution in the size of the nucleus from the basal layer, which has the biggest amount of chromatin. Okay. And then as you go up to the stratum corneum, you would see flattening of the cell with accompanying thinning out of the nucleus. So we go to this area where you need have the presence of atypia. So in the classification for dysplasia in the cervix, initially in the 70s and 80s, they were using a classification based on the dysplasia. They would term it as mild, moderate, and severe. And then you have the carcinoma inside too as the fourth classification. And then this was followed up by another group, and they would label it as the cervical intraepithelial neoplasia. Okay, with the 3-tier classification, CIN 1, 2, and 3. Okay, so when you say cervical intraepithelial neoplasia, there will be the presence of atypical cells within the epithelial structure, and it is limited by the basement membrane, which means that there's absence of stromal invasion. Okay, so matatawag mo lang siya as CIN. Okay, but if there's stromal invasion, then you call it as squamous cell carcinoma. Okay. So the CIN classification would be dependent on the location of the atypical cells. Okay. So naturally, we would look into the lowest portion, okay, because that's where the basal layer are. Basal cells are, and that would be our benchmark. Okay, so the cells there are immature, okay, with the normal cervical lining. Okay, so there should be maturation in normal epithelium. Here there would be the presence of atypical or the immature cells going into the upper portion. So if it's limited up to the lower 1/3 of the epithelium, it would fall under CIN1. If the atypical cells would be seen on the lower 2/3, it would be labeled as CIN2. And if it goes up to the if it involves the entire layer of the epithelium, then it would be labeled as CIN3. Okay? So, sinabi ko yung previous classification and the current classification because in the previous classification we have four classes or categories. In the current classification, you only have 3. So the carcinoma in situ was labeled under CIN3. Okay? So the difference between the severe dysplasia and CIN3, okay, wherein it would already encompass the carcinoma in situ would be based on the uppermost portion. Okay? So if you see the presence of mature flattened cells in the uppermost portion, it would still fall under CIN3 in the current classification. But in the old classification, it would fall under the severe dysplasia. Okay? So if there's still maturity on the uppermost portion, then that's labeled as severe dysplasia. Okay? But if you have the presence of atypical cells in this one, up to the uppermost portion, this would be labeled as carcinoma in situ in the old classification, or CIN3 still in the new classification. Okay? So that's the difference. So mild dysplasia and moderate dysplasia would correlate well with the classification of CIN1 and 2. Okay, yung lower 1/3, lower 2/3. Okay, yung CIN3 lang and severe dysplasia and the carcinoma in situ would have a variation. So when you say dysplasia, it would mean that there's pleomorphism, there's hyperchromatism. Okay? So you can see variation in the size and shape of the nucleus, and then you have darkening of the chromatin. This one is a mitotic figure. And then what about this one? Okay? So, is this a sign of libation? So in the classification for CIN1, this would still be labeled as carcinoma. This would fall under cervical intraepithelial neoplasia and not under squamous cell carcinoma. Okay. This would mean that there would be an extension of the atypical cells towards the glands, and they would call this one as a CIN with glandular extension. Okay, so this is not yet a sign of stroma invasion. So it is not a nest. You can see that that there's still the presence of the basement membrane. Okay, that would be continuous with this cervical gland. Okay. So it would mean that this one was a previous metaplastic area, okay, that had undergone dysplasia. So this would still be cervical intraepithelial neoplasia. So CIN pa rin yan, ha? You always look at the basement membrane. Okay? So if it's still intact, then it's a carcinoma inside. The same goes with the rest of the 7.
Invasive squamous cells. Invasive squamous cells.
So here are some of the portions of the slide for slide 17. You can see large dilated cervical glands. Okay. I think this was tackled in the first part of the cervical discussion. If you have dilated glands like this one, that would be attributed to environmental change. And there's entrapment of the mucus. These are called the Nabothian cysts. Okay. Nabasa niyo ba yun? Nabothian cysts. So, This would this can be part of the cervical structures that we will see. And then we have here the portions of the malignancy. Notice that you still have glands over here, and then you have the typical cells over this portion. Okay, so squamous cell carcinoma is associated also with the human papillomavirus, same as that of the carcinoma itself. You would see the presence of nests of atypical squamous cells. Okay, so how do you know that this is coming from the squamous epithelium? So just look for the origin. Always look for the origin. So it's coming from the uppermost portion going downwards, and it would mean that it's epithelial in nature. So sometimes you would encounter metastatic lesions. Okay, and usually the upper portion is intact. Okay, metastatic lesions would be seen on the lower portion, okay, underneath the normal ones. Dapat there should be a bridge or a connection between the uppermost portion and the lowermost portion. So you can see here the nests, the typical cells. Prominence of the nucleoli. You have individual cell organization. You have the pink cytoplasm, or what they would call as orangophilic cytoplasm. And in the female genital tract, usually the category for classifying squamous cell carcinoma will be dependent on the keratinization, okay, and then the size of the cells. Unlike in the other organs, wherein we would classify them as well differentiated, moderately differentiated, or fully differentiated type. Here we would label as squamous cell carcinoma as large cell type, keratinizing or non-keratinizing. And then you have the squamous cell carcinoma, small cell type. Nandun ba yun sa book? And then yan, sa blue yata yan. Okay, yun sa highlighted. So, large cell carcinoma, these are the ones, okay, that are linked to this large cell carcinoma. Small cell carcinoma, if you remember the small cell carcinoma of the lung, okay, that's the appearance wherein you have the nuclear molding. That would be a feature for small cell carcinomas. Okay. And then the difference between a large cell carcinoma keratinizing and a large cell carcinoma that's non-keratinizing would be with the presence of keratin pearl. Okay. So even if there's individual cell keratinization, if you do not see keratin pearl formation, then you will label it only as a non-keratinizing. Okay? So kahit ito lang makita nyo, wala kayong makitang keratin pearl like this one. Okay? Then you label it as non-keratinizing. This one has a keratin pearl. You can see that there's a concentric lamination of keratin, okay, wherein you have entrapment of the squamous cells. This is a keratin pearl. Okay? So anything like this one, this is also a keratin pearl. Okay? Smaller version. Wherein concentric lamination with entrapped squamous cells, you have dense keratin. That's keratin pearl formation. So this is labeled as squamous cell carcinoma, large cell keratinizing. So that's the terminology that we use for squamous cell carcinoma of the female genital tract. Next we have 75. Endometrial ba ito? Okay. If you are going into OB, you should be familiar with the menstrual cycle. Okay? So, meron kang proliferative, okay? Then you have the different phases, early, mid, and late, and then secretory, early, mid, and late, and then the histologic features. Okay, nakita niyo yung tabulation, okay, wherein you have stratification of the nuclei, kakaroon ka ng mitosis, and then you have the subnuclear vacuolations, stromal edema, okay? Although mahirap siyang intindihin, okay, but you get to know the particular dates of the endometrium, especially if you're thinking of having an ovulatory cycle, okay, and the OB would like to date, okay, which particular period is the patient undergoing. So kung secretory ba or proliferative, and that's where the treatment will come. Okay? Okay, so in endometrioid carcinoma, actually they would call all malignancies of the endometrium as endometrial carcinoma. Okay? I don't know with the book kung na-categorize pa nila yun. So there are several classifications for endometrial carcinoma. The most common of which would be the endometrioid type. Okay? So this one, I think this is labeled as endometrioid adenocarcinoma. Okay? They would also call it as adenocarcinoma, endometrioid type, endometrium. Okay? Because endometrioid adenocarcinoma can also be encountered in the cervix, can also be encountered in the ovary. That's why we have to place there the location. Okay, so it's adenocarcinoma, endometrioid type. Okay, it's called endometrioid type because it mimics the appearance of the cells found in the endometrium. Okay? Yung columnar. Okay, so the typical appearance of endometrioid adenocarcinoma is that they are configured in back-to-back formation. Okay, some are fused. Okay, like this. And they are seen infiltrating the myometrium. Already the myometrium. Sometimes the endometrioid adenocarcinoma will be confused with one benign lesion or condition, which would be the, alam niyo ba, it's adenomyosis. Okay? Because when we look at the slides, the myometrium would also be infiltrated by islands of normal glands, okay, and stroma. So you have to look for cells that are that look benign, and aside from that, they are accompanied by the stroma. So in this case, the infiltration here would be by the epithelial cells only, not accompanied by the stroma cells. And usually the endometrioid adenocarcinoma, this one would be seen in the perimenopausal and menopausal. The ones with the poor prognosis are not the endometrioid, but the clear cell type, okay, of adenocarcinoma, which would be seen in the elderly individuals. Okay. Again, this is the appearance. We are seeing back-to-back formations. So, adenocarcinoma. Wala na sila. Ano yung sunod natin?
78.
78. So, this slide is a review for you. We have encountered this one in inflammation. Chapter inflammation. Okay, so acute salpingitis. So when we say salpingitis without an H, baka mamaya in your practice, maglalagay kayo ng salpingitis. So, salpingitis siya. S-A-L-P-I-N-G-I-T-I-S. Kasi minsan, I get to encounter biopsy specimens, okay, wherein they write their salpingitis. Okay? So, i-correct nyo na yung sarili nyo as early as now. That it doesn't have an age. Okay? So, in acute salpingitis, this is part of the pelvic inflammatory disease or the PID, okay, wherein there's inflammation of several organs found in the female genital tract. Okay? And this is attributed usually to sexually transmitted disease like Neisseria gonorrhea and Chlamydia trachomatis. Yun yung usual na dalawang culprits. So there's inflammation of the plicate, okay, of the fallopian tube. When you have mixed infiltrates, nakita nyo naman yung slide na to. It's labeled as acute salpingitis, kaya lang there's already the presence of mononuclear cells, okay, accompanying the neutrophils. Okay, so ito may mga neutrophils kayo, but you also have histiocytes and lymphocytes. Okay. Next.
79 po.
79. 79. Ay. Meron na. Change to. So, next is 79. This is leiomyoma. So, this is a very common tumor, especially in females. Leiomyomas are hormonally induced. Okay? They can become big during times of pregnancy. That's why other females who are bearing their pregnancy, sometimes they have an accompanying enlargement of the myomas that they have prior to their pregnancy. From 1 cm, they become 10 cm. Okay, and then they can obstruct the pregnancy. Okay? So it can cause complications towards the baby and towards the mother. Okay? So the leiomyomas are benign tumors consisting of smooth muscle fibers, and they are arranged in such a way that they are interlaced. There's alternating patterns of longitudinal and circular patterns. So longitudinal, okay, then you have your circular, okay, longitudinal again, and then you have circular. Okay. So alternating patterns. So there are interlacing fascicles of smooth muscle fibers. And according to location, kung nabasa nyo na yung book nyo, there are 3 common locations, okay, within the myometrial wall. One is intramural, nasa gitna siya ng myometrium. Submucosal, underneath the endometrium. And then subserous. Okay? Subserous are, usually they would appear as pedunculated, nakalawit na from the uterus. Okay? Usually the one that would cause the bleeding would be the submucosal tumors. Okay? Because they are lying immediately under the endometrium. Okay? And it will cause irritation kasi nagbabanggaan yung endometrium on the anterior wall, okay, and then on the posterior. So it would be a cause of bleeding. Okay? So tandaan niyo yung location na yun. Submucosal, intramural, and subserous and subserosal. So this is a benign tumor.
82. 82. Okay. Ang 82, I think there are 2 lesions for slide 82. So this one is
what is labeled in your manual, ovarian endometrioid carcinoma. So this is an adenocarcinoma, endometrioid type. Okay, it mimics the lining, okay, or the epithelial cells found in the endometrioid. So based on the classification for ovarian neoplasms, there are 4 categories. Okay, yung surface epithelial, we have the sex cord stromal, okay, and then we have the germ cell tumor. Okay, so those are primaries. Okay, surface epithelial, sex cord stromal, germ cell tumor. Okay, and then you have the 4th category, which is the metastatic lesion. So may mga metastatic lesions din that would be seen in the ovary. So under surface epithelial, you just think of anything that would be coming from the epithelium. Okay, serous, mucinous, transitional, okay, Brenner tumor. So yun yung mga classification, and the endometrial. Okay, and the endometrial. So this one would fall under the endometrial. This would be the 3rd most common. Okay, pinaka-common is serous, followed by the mucinous, and then 3rd yung endometrial, and then you have the transitional. Okay, so for endometrioid type, unlike yung mga serous and the mucinous, wherein benign tumors are the most common form, dito sa endometrial, rarely do we see endometrial forms na benign. Okay, more common yung malignant na sila. Okay, so this one is endometrioid type. Alam niyo na yan. Okay, adenocarcinoma, back configuration. You have tibia. Okay. 83. Wala rin ako. 83 is papillary. Papillary serous.
Papillary cyst.
So ito na-take up niya na rin ito nung ano, di ba? Neoplasia. Naalala niyo pa ba? Pero parang maliit. Ayan. So, yeah, pa natin post the issue here. I think it's coming from the peritoneum. Here is fibrocollagenous tissue, and then you see the papillary structures, this portion. So, papillary serous carcinomas. For serous tumors and mucinous tumors, again, if you have read the book na rin, they would be labeled as benign, borderline, or malignant. Okay? So, pag sinabi mong benign, you have serous tumors that are lined by a single layer, then they look benign. Okay? For borderline, there would be a stratification of the cells, like this. There would be stratification, and then you also have the variation in the size of the nucleus. Okay? But the differentiating factor between borderline tumor and malignant tumor would lie in stromal invasion. Okay? So very important yung stromal invasion. Borderline tumors, parang they label them as intraepithelial neoplasia, pero hilaw. Okay? So borderline tumor, that's why some would undergo chemotherapy, others they do not. So that's the difference. Stromal invasion is very important. You have to look for stromal invasion. If you do not see stromal invasion, then it can be borderline. But for this one, we can see that there's already invasion into the stroma. Like this one. Serous papillary would be characterized by having a papillary core like this one. Okay, having a fibrovascular stroma. They are arranged in papillary formations. Ano pa tayo ng ibang papillary formations? When you see papillary core, kasi the center area or the central portion would have blood vessels and fibrovascular and fibrous tissue. Ito, fibrovascular. Okay, papillary core, and then you have the presence of a fibrovascular structure. So actually ito artifactual yan ha. Hindi sila bilog. Pagka nakita natin sa cross, hindi sila bilog. They are actually like papillary fronts. Okay, but when you cut it, they would be cut in the center, sagittal, and that's the appearance. Okay, napuputol yung papillary excrescences. That's what will happen. Okay. I don't know if this slide has a feature that will be seen in papillary lesions, and that is the samoma body. Okay, ito, yan. Samoma bodies yan. Okay, so there are concentric hyaline lamellations that can be seen in papillary lesions. So when we go into endocrine pathology, okay, you encounter the papillary carcinoma of the thyroid, pwede nyo makita ito. Okay, so it can be encountered in any papillary neoplasm, whether it's benign or malignant. So not necessarily na meron kang nakitang sa mama body, then you would say, yeah, this is malignant. Okay, so it can be seen in benign or malignant neoplasms, papillary type. So kahit saan na, anywhere in the body, as long as it's papillary, there's a chance that it will see sa mama body. Next.
88.
88. Malaki. So 88, this is mature cystic teratoma. Okay, so mature cystic teratoma. For mature teratomas, they can be solid or they can be cystic. Okay? Pag sinabi mong teratoma, it would mean that there's a mixture of the different germ cell layers, yung ectoderm, mesoderm, endoderm. Lahat sila rolled into one, nandun sa isang tumor na yon. Okay? And they're usually benign. When we look at the gross specimens for mature teratomas, we often would see the presence of a cyst that would contain sebum, okay, yung taba. Taba ba tawag doon? Coming from the sebaceous glands. And then we also have hair. Occasionally, you would appreciate the presence of tooth or teeth, yung mga ngipin. And then when we cut the lining or the wall, it's sometimes hard, which means that there's a presence of a cartilage or a bone. So, yun yung mga nakikita mo. Okay? Lining epithelium, the most common that we see would be the stratified squamous epithelium. And then you have the presence of sebaceous glands, denoting that it can be mimicking the skin. We have muscle here, fats, endocrine glands. Okay. This is part of the ovary, okay? Corpus corpora albicans. Okay? So that's the remnant of the corpus luteum. So I think that's about it that we will see here. Okay, for teratomas, it would be classified into three. Okay? Meron tayong mature teratoma, we also have the immature teratoma, and then the malignant teratoma. Okay, so when you say mature, kailangan all of the elements from the germ cell layers would be mature. Okay? Walang malignant. Then you have the malignant teratoma, wherein you have the presence of squamous cell carcinomas, adenocarcinomas, with the normal elements. Okay? Sometimes they wouldn't call it as malignant teratoma, they would call it as a mature teratoma with malignant transformation. Okay? Because it would arise from the mature ones. And then the third classification for teratoma would be the immature teratoma. Okay? In immature teratoma, you do not see mature elements. What you see would be undifferentiated cell lineage, and then the characteristic feature that should be seen would be the presence of neuroepithelial tissue. Okay, pag nakita nyo yung neuroepithelial tissue, tingnan nyo lang sa book. There's a picture there, or I think I have a slide I'll show to you next meeting. Okay, the presence of neuroepithelial elements. Okay, and they are graded according to the amount of neuroepithelial elements. So mas marami, mas fully differentiated siya. Okay, it's malignant. Okay? And then we also have specialized teratoma. Okay, pag sinabi mo specialized, they are what they call as the monodermal type. Okay, kasi yung mature teratoma, you have different germ cell layers. Ito, monodermal. Ibig sabihin, isa lang talaga yung particular na pinanggalingan nila. Okay? So, usually the one that you encounter will be the struma ovary. Okay? S-T-R-U-M-A O-V-A-R-I-I. Okay, struma ovary. In this case, patients tend to have enlargement of the thyroid gland. Okay, because of a hyperfunctioning struma ovary. Nagiging hyperthyroid siya, yung pumapayat din. Okay, so all that because of the presence of thyroid tissue in the ovary. Okay? Struma ovary. Baka meron din ako niya.
90 po.
Okay, 90. So we have encountered surface epithelial tumors. Okay, tandaan niyo lagi yung mga classification. It's very essential that you know them. Surface epithelial galing sa epithelium. Okay, serous, mucinous, transitional Brenner, and then the endometrial types. Okay, ito na-tackle na rin natin ang germ cell. Okay, that's the most common yung teratoma. This one is coming from the third type. Okay, and that's the sex cord stromal. Okay, sex cord stromal. So granulosa cell tumors, we would call this one as the great mimicker of neoplasms. Okay, because when we cut the gross specimen, we would be thinking of another lesion. And then when we look at it in the microscope, this one is granulosa. So initially, we would not be thinking of granulosa, but when we look at it, it's granulosa cell. So granulosa cell tumor would be coming from the derived from the follicles. Okay, you have the granulosa cell there, and when you have a granulosa cell tumor, this one can be seen in the young adults or in the older individuals. Okay, kaya may tawag sa kanilang juvenile granulosa cell tumor and the adult type of granulosa cell. Granulosa cell tumors are functional tumors. Patients with granulosa cell tumor can have hyperplasia of the endometrium. So magkakaroon siya ng simple or complex hyperplasia or even carcinoma, yung endometrial type. And sa breast naman, they can have fibrocystic change. Okay? So, granulosa cell tumor is associated with epithelial cell proliferation in the endometrium and in the breast. Okay, so ano niyo malaman kung granulosa cell tumor? Here you would see the presence of nests. And then within the nests, you would see something that's very typical of granulosa cell tumors. You have small follicles of the tumor cells, which would be called the call X nerve bodies. Okay? Called Exner bodies. C-A-L-E-X-N-E-R. Okay? Called Exner. So, nasa book din yan. Kung hindi nyo ba nabasa. Na-encounter ba to sa lecture? Okay. So, when you say granulosa cell tumor, okay, pag sinabi niya Paul Exner body, that's consistent with granulosa cell. Okay? Walang ibang tumor sa ovary na merong Paul Exner body. Okay? It's the only one. So, when you say Paul Exner, you will see them in follicles. Paul Exner bodies. Okay? And then, very characteristic also of the granulosa cell. Ito yung mga granulosa cell. It's vesicular. Ibig sabihin, translucent siya. Okay? Translucent. Parang nakikita mo yung kaluluwa. Okay? And then, you also see the presence of grooves. There's a groove here in the center. Having a coffee bean appearance. Okay? So that's very typical of granulosa cell. Kasi minsan we would have a problem if there's absence of Cole-Exner bodies. So when we look into the individual cell, so if we see vesicular nuclei with grooves, okay, showing coffee bean appearance, okay, para siyang coffee bean, nakita na kayong coffee bean, may ano sa gitna, okay, so that's called that's a granulosa cell. Okay, next.
104.
Polycystic. Okay. Ano ba yung slide mo? Sa iba yung binungkit. 101, chronic gastritis. Okay, so polycystic ovary is associated with infertility. Okay. During the course of the menstruation, natural lang naman for females to have cysts. Magkakaroon ng small cystic follicles. Okay? So if some of you would encounter cousins or mga titas na ganyan, they would be asking you na, is it okay if we have cystic follicles, okay, on ultrasound? It's okay because it's part of the hormone reaction. Okay? So, nagkakaroon talaga ng cystic follicles, and it can regress, nawawala sila, unless they are very big. So, in polycystic ovarian disease, it's associated with infertility. Okay, so you see the presence of cysts. Cysts in the book, they would have multiple cysts ranging from 0.5 to 1.5. Ito parang mas malaki na yata. Okay, so when you say multiple cysts, parang naka-mapa ano siya within the entire ovarian stroma. This is stroma. Usually this is associated with anovulation, infertility, with hypothyroidism, and diabetes mellitus. Next. Choriocarcinoma. So, choriocarcinoma would fall under the gestational trophoblastic disease. Okay, so in GTT, in gestational trophoblastic disease, meron tayo yung hydatidiform mole, okay, or the H mole, and then we have the choriocarcinoma, which is the malignant lesion. Okay, so for hydatidiform mole, it can be partial or complete, depending on the presence of the fetus as well as the variation in the size of the molar structures. I'm telling you this one because this is one thing that will be able to differentiate choriocarcinoma from H mole. Okay, in hydatidiform mole, you would see the presence of chorionic villi
papakita ko sa inyo kung ano yung tsura ng chorionic villi next week. So chorionic villi, as well as the presence of trophoblasts. So that's the TB4 mole. Even in invasive mole, wherein the chorionic villi would go into the muscle layer na. Okay? And choriocarcinoma, if you do not see the presence of chorionic villi, only trophoblasts, then choriocarcinoma yun. Okay? If you see the presence, kahit na isa lang na chorionic villi, invasive mole siya. Okay? Ganun ka-importante ang pag nakita mo yung chorionic villi. Okay? Pag walang chorionic villi, choriocarcinoma. Choriocarcinoma is highly malignant. Okay? It's aggressive. It can eat up the entire myometrium. Okay, so choriocarcinoma would be a mixture of the different forms of trophoblast. Meron actually tatlo. But in choriocarcinoma, you can see only two. Okay? We have the cytotrophoblast and the syncytial trophoblast. Pag sinabi mong syncytial, these are the large cells. It can be multinucleated. Ito, like this one. You have abundant cytoplasm. So these are examples of syncytial trophoblasts. Yeah. And then you have the smaller cells there. Okay. Small round nuclei with scanty cytoplasm. Okay. So that's the cyto. Okay, cytotrophoblast. And then you have the intermediate. Okay, if you have small nuclei but you have abundant cytoplasm, okay, yung parang naging in between siya, that's the intermediate trophoblast. So as you can see here, it's highly malignant because you have areas of hemorrhage, necrosis. Usually when you have a highly malignant or aggressive tumor, usually the surrounding structures it has a lot of hemorrhage and necrosis.
Tapos,
Wala na? Wala na?
yes.
Patingin pa namin. Parang nabitin ako. Okay. So next week, we're going to have cross specimens. And ano pa ba? I have slides, other slides para maano nyo naman, ma-appreciate nyo yung other areas because we have so many